this is the frontal bone, which is unpaired bone. We have two parietal bones, or paired parietal bones. We have a single occipital bone at the back, and we have this paired temporal bones, and we have, paired temporal bones, and this circular region, which is present here, is the thinnest part of the skull, and it is very important clinically. This region, or this part, is called pterion. The bones of the skull are basically attached with each other through sutures, which are fibrous joints basically. And these sutures are, we have this coronal suture. I think I need a mouse. This coronal suture, which is present between the frontal and parietal bones. We have this lambdoid suture posteriorly between the parietal and the occipital bones. And this is the squamous suture. Excuse me, I need a mouse. Cursor is please. This is a part which I was talking about, is the thinnest part of the skull where four bones meet, and this point is called pterion, and four bones that met at this point are basically the frontal bone, the sphenoid bone, the parietal bone, and the temporal bone. What is the significant? Why this point is significant is because here beneath this pterion, or thinnest part, is the branch of the maxillary artery, which is the which is the middle meningeal artery that passes beneath this point, and damage or blow to this point can cause this epidural hematoma. Obviously, this is a life-threatening condition. Next is the frontal view of the skull. We have different bones of the skull. We have nasal bones, we have lacrimal bones, we have vomer, we have nasal concas, zygomatic bones, maxilla, ethmoid bones, and the mandible. All these bones makes up the facial skeleton of the skull, or make the facial skeleton. What important is basically the differences between the male and female skulls. Male skulls basically are larger, they are heavier, and they are more rugged muscle markings and prominences. And male teeth are larger, they are more squared incisively, and the forehead is flatter as a result of developing frontal sinuses, which are larger in men. Yes. In the male skulls, we have large brow ridge, we have sloping forehead, and we have mastoid process, which is very prominent here. And the angle of the jaw is basically acute angle, and we have chin, which is square. In case of female skulls tend to be smaller, they are lighter, and have thinner walls. And female forehead usually retains a round enlargement at the occipital region is also less prominent here. And the chin is more pointed. These are very important for the MCQ point of view, difference between the male and female skull. Now, we can divide the head into different areas and regions, which are very important. We can divide it into the scalp. We have cranial fossas, we have temporal fossa, we have infratemporal fossa, we have pterygopalatine fossas. I will discuss it one by one. First of all, scalp. Scalp is basically the outermost layer of the skull. Outermost layer of the skull, and it consists of or comprises of SCALP, as it spells, skin. We have a connective tissue layer, and we have aponeurotic layer, we have loose areolar connective tissue layer, and we have a pericranial layer. So SCALP, scalp, stands for all these layers. Now, what is important? What important is there is a dangerous layer which बहुत सारे MCQs मैंने देखे हैं, तो उसमें जो है they will ask about the dangerous layer of the scalp. The dangerous layer of the scalp is basically the loose areolar connective tissue layer. Why it is called the dangerous layer of the scalp? Because imagery veins pass through all these layers, and these imagery veins basically connect the superficial part of the superficial part or scalp into the dural venous sinuses. So infection in this area, in area of scalp, or in case of any wound or injury, infection goes directly to these dural venous sinuses, which can be lethal. So the dangerous layer is basically the loose areolar connective tissue layer. Now coming to the blood and nerve supply of the scalp. When we talk about the nerve supply of the scalp, anterior to posteriorly, we have this supratrochlear nerve, we have supraorbital nerve, then we have auriculotemporal nerve, we have lesser occipital nerve, we have greater occipital nerves, and we have third occipital nerve. And when we talk about the arterial supply or venous drainage, so all these vessels are basically named after the region. They are a region where they are. We have supratrochlear arteries, or again they are accompanied by their veins. We have supratrochlear artery, we have supraorbital artery, we have superficial temporal artery, and we have this posterior auricular artery, and we have occipital artery. So this is the blood and nerve supply of the scalp region. Now, this is a complicated slide, and this basically shows the cranial fossas. Cranial fossas. This is on the left side, we have the interior part of the skull, and on the right side, we have the base of the skull. Thank you so much. Sorry. Now, anterior to posteriorly, we should know all about the openings which are present on the interior and the base of the skull. These all are very important for the MCQ point of view. This is the interior of the skull, this left side, and we can divide this interior of the skull into different fossas. We have anterior, middle, and posterior cranial fossas. When we talk about the anterior cranial fossa, we have this sieve-like structure, which is called the cribriform plate of the skull. This cribriform plate is basically sieve-like, and it is very important. Olfactory nerve, sensory neurons from the olfactory epithelium, their axon pass through this cribriform plate, and they will form the olfactory nerve, which is the first cranial nerve. And another important point clinically, which is very important, is damage to this cribriform plate. It causes the flow of CSF from the brain tissue up to the brain tissue to the nose. So this is clinical important. Anterior and middle cranial fossa, we have other openings, which are, this is a large opening, which is called the superior orbital fissure. And it is also very important because the important cranial nerve, fourth cranial nerve, we have oculomotor nerve, we have abducent nerve. All these nerves pass through this superior orbital fissure. So damage to this fissure also causes damage to all the structures which are supplied by these cranial nerves. Then we have the optic canal. Optic canal passes the optic nerve and ophthalmic arteries. So, and other openings which are present in the middle cranial fossa are foramen rotundum, which is a very small opening, and that passes the maxillary division of the trigeminal nerve. We have this foramen ovale, which passes the mandibular division of the trigeminal nerve and lesser petrosal nerves. Then we have this carotid canal that passes the internal carotid artery along with its nerve plexus. And then we have this foramen spinosum for the middle meningeal artery, which we are talking about related to the pterion. Then we have the openings at the junction of middle and posterior cranial fossa. In these openings, this is the large opening, which is called the jugular foramen. And jugular foramen houses the important nerves, which are 9th, 10th, and 11th cranial nerves, which are glossopharyngeal, vagus, and the accessory nerve. Here we have hypoglossal canal, which houses the hypoglossal nerve, which is the 12th cranial nerve. So in a sequence from anterior to posteriorly, we have olfactory nerve from cribriform plate. We have second nerve, that is optic, from the optic canal. We have third, fourth, and part of 5th cranial nerve, which is oculomotor, trochlear, and trigeminal divisions. These pass through superior orbital fissure. Then we have the 7th cranial nerve, which passes through the internal auditory meatus, auditory canal, which is also present at the junction of the middle and inferior cranial fossas. So 7th, 8th cranial nerve, which is vestibulocochlear, it also passes with the facial nerve. Then we have this 9th, 10th, and 11th nerve that passes through this jugular foramen. And we have the 12th cranial nerve, which passes from the hypoglossal canal. Now, coming to the base of the skull. From base of the skull, basically, all the nerves and vessels, basically, they enter through these foramen from interior of skull, and they exit it, or a few entered in the base of the skull. Base of the skull. So if you should know the interior of the skull and the foramen and their content, this is very easy to enumerate or enlist all the components of these openings. Now, coming to the fossas, or the structures which are present on the facial region, we have temporal fossa. Temporal fossa is present on the lateral side of the skull. And this temporal fossa is bounded superiorly by the superior temporal lines and inferiorly by the zygomatic arch, which is the part of the facial skeleton. And this fossa basically comprises of the deep temporal arteries. First of all, temporalis muscle. This is a large muscle. We will talk about this muscle in the muscle section. This is a muscle of mastication. So this is a temporalis muscle that covers the whole part of this temporal fossa. We have deep temporal arteries, we have deep temporal nerves, and we have the zygomaticotemporal nerves. We have middle temporal artery, we have superficial temporal artery, and we have auricular temporal nerve. So all these structures are present within the temporal fossa, and you should know about the contents of these fossas. Then we have the infratemporal fossa. Infratemporal fossa is present just beneath the zygomatic arch, and it communicates with the temporal fossa behind this zygomatic arch. This is a zygomatic arch. This is this is a zygomatic arch, and this is a communication between the temporal and infratemporal fossa. So the boundaries of the infratemporal fossa are formed by anterior wall is formed by the posterior surface of the maxilla. When we talk about the lateral wall is basically the ramus of the mandible. If we talk about the medial wall of this fossa, medial wall is formed by the lateral pterygoid plate. And posterior wall is formed by the tympanic plate and the styloid process. And the roof of this fossa is basically the infratemporal surface of the sphenoid bone. This yellow part, bone is basically the sphenoid bone. And when we talk about the contents of this fossa, we have the mandibular division of the trigeminal nerve. This is a trigeminal ganglion, and this is the mandibular division of the trigeminal nerve. We have a very important structure, which is a parasympathetic ganglia present in this region. This is otic ganglion. We have also the branches of the chorda tympani, which is a branch of the 7th cranial nerve, facial nerve, which is present here. And we have the lateral pterygoid muscles, which are present in this region. And also, this is the external carotid artery. And external carotid artery gives off maxillary artery. So the part of the maxillary artery, along with all its divisions, are also present in this infratemporal fossa. Then we have the pterygopalatine fossa. Pterygopalatine means pterygoid plate or palatine bones. So the fossa present between these two structures is called the pterygopalatine fossa. This is basically a small pyramidal space that is inferior to the apex of the orbit. This is a little bit tilted skull and right side of the skull. Apex of the orbit and medial to the infratemporal fossa. This is a zygomatic arch. Above this arch is the temporal fossa. Below is the infratemporal fossa. And medial to this infratemporal fossa is this pterygopalatine fossa. Anteriorly, it is bounded by the maxilla. Medially, we have lateral pterygoid plates. Laterally, we have infratemporal fossa. So these are the boundaries of this fossa. Now, the important thing is basically the communications of this pterygopalatine fossa. Obviously, for MCQ point of view, this is very important. This pterygopalatine fossa basically communicate with the nasal cavity through sphenopalatine foramina. And to the floor of the orbit through inferior orbital fissure. This is the anterior communication. This is the superior communication. And now we have these posterior communications of the pterygopalatine fossa. It is basically communicate with the nasopharynx through pharyngeal canal. It communicates with the middle cranial fossa through foramen rotundum. It communicates with the base of the skull through pterygoid canal. And inferiorly, it communicates with the oral cavity through greater palatine canal. These communications are basically very important for your MCQs. So you should know about all these communications and the structures that which are responsible for these communications. Now we have the contents of this pterygopalatine fossa. We have a very important vessel. This is basically the external carotid artery. External carotid artery gives off maxillary artery behind the ramus of the mandible. The first part of the maxillary artery is present in the infratemporal fossa. The second and third part of the maxillary artery are present in the pterygopalatine fossa, and it gives off branches there. Second important structure which is present here is another parasympathetic ganglia, which is called the pterygopalatine ganglion. We have the maxillary division of the trigeminal nerve, which is also present here. And all these nerves and vessels gives off branches, which we discuss inshallah later. Now we have muscular groups which are present in the head and neck region. We have 7 main group of muscles. These are muscles of the facial expression. We have muscles of the mastication. We have muscles of the tongue, soft palate. We have muscles of the floor of the mouth, muscles of the pharynx, muscles of the neck. Now, starting with the muscles of the facial expression. से अगर आपको मसल्स ऑफ द फेशियल स्कैल्प पता है तो आपको इससे अंदाजा हो जाएगा कि कौन सी नर्व ब्रांच जो है वो कौन से मसल्स को इनर्वेट करती है और इन केस ऑफ डैमेज टू दीज नर्व्स जितने मसल्स पैरालाइज होंगे यू कैन इनोमरेट इफ आपको इसके एरियाज जो हैं वो उनके पता हो. Again, a very important clinical condition which is the facial nerve palsy. और वो obviously associated है जैसे मैंने अभी temporal branch basically होते हैं. Again, उन सबके साथ वो associated है. बक्कल ब्रांच जो है वो associated है. We have oral cavity जो कि हमारे lower lip के साथ associated muscles हैं, वो सारे उनके साथ associated है.
Recording in progress.
Now we have the ophthalmic and maxillary division of the trigeminal nerve. So these important cranial nerves, they pass through the lateral wall of this cavernous sinus. And from the middle of the sinus or the body of the sinus से जो है वो आपके internal carotid artery along with its plexus ये pass होती है. So inflammation or damage to this sinus basically damages all the structures which are innervated or which are dependent upon all these cranial nerves. तो इसलिए जो है हमारे कैवर्नस साइनस की जो है वो बहुत इंपॉर्टेंट है. कोई भी इन्फेक्शन थ्रू स्कैल्प, जो हमने बात की थी पहले कि डेंजरस लेयर ऑफ द स्कैल्प एमिजरी वेन के जरिए से ड्यूरल वेनस साइनसिस में आ सकता है. एंड्यूरल वेनस साइनसिस ऑब्वियसली दे आर इंटरकनेक्टेड, वहां से आ सकता है. देन important one is the connection with the facial vein, जो कि हमने dangerous area of the face किया था. तो important connection is that कि deep facial vein is directly connected with the pterygoid venous plexus, and pterygoid venous plexus drains is connected with the cavernous sinus. और इसके अलावा ophthalmic veins हैं जो कि directly connected हैं with the cavernous sinus. तो ये दो routes हैं कि जिनके through इस sinus में जो है वो infection या inflammation आ सकती है, और that is lethal. Then we have organs of the head. Organs of the head की जब हम बात करते हैं तो उसमें हमारे पास आ जाता है nasal cavity है हमारे पास, और paranasal sinuses है. Nasal cavity is divided into external nose and the nasal cavity proper. External nose is made up of the bones. These are the nasal bones and the cartilages. और हम बात करेंगे अभी सिर्फ nasal cavity proper की. Nasal cavity proper consists of bony projections which are called the concas, and we have the superior, middle and inferior concas, and the space between these concas are called the myiatises. We have superior, middle and inferior myiatises, and all these nasal sinuses जिनके बारे में भी हम बात करते हैं, they open into these nasal myiatises. तो what to remember is basically कि आपको जो openings present हैं in meatus में उनका पता होना जरूरी है, and that is important for your MCQs. So we have a superior nasal superior meatus and medial meatus में जो अगर आप देखें तो आपको ये ओपनिंग नजर आ रही है sphenoidal sinus की. Sphenoidal sinus के अलावा जो है we have openings of the posterior ethmoidal cells. ये दो चीजें जो हैं वो आपको याद रहनी चाहिए कि जो है वो इस ओपनिंग में obviously MCQs किसी पैटर्न पे जो है वो बनते हैं जो one liners होते हैं. Then we have this middle meatus, and middle meatus में अगर आप देखें तो this is the opening of the middle ethmoidal cells, and this is a hiatus for or opening for the anterior ethmoidal cells, and frontal sinus opens into this middle meatus, and we have this opening of the maxillary sinus. So maxillary sinus, frontal sinus, ethmoidal sinus, तो ये सारे के सारे आपके ओपन होते हैं मिडिल मियाटस में. देन वी हैव द इंफीरियर मियाटस. इंफीरियर मियाटस में जो है वो आपकी ओपनिंग ऑफ द नेसोलैक्रिमल डक्ट होती है, दैट इज इंपॉर्टेंट. तो ये हो गया आपका नेजल कैविटी प्रॉपर और ओपनिंग्स व्हिच आर प्रेजेंट इन these in the lateral wall of the nasal cavity or nasal cavity proper. Then we have these paranasal sinuses. Paranasal sinuses जो है वो अगर हम देखें तो basically these are air filled spaces that surrounds the nasal cavity. Paranasals, they increase the resonance of voice. They basically prevent the facial trauma. So all these are the functions of these nasal sinuses. And we have this group of sinuses, which are the frontal sinuses, which are present in the frontal bone. We have ethmoid sinuses present in the ethmoid bone. We have maxillary sinuses, which are present in the maxillary bones. And we have sphenoidal sinuses. All these sinuses, जैसे हमने देखा, they open into the this nasal cavity proper or on the lateral wall of this nasal cavity. तो पता है aligned sinuses or obviously जो ब्लॉकेड होता है तो साइनसाइटिस जो है देन एक्यूट एंड क्रॉनिक साइनसाइटिस की कंडीशंस भी क्या होता है जो कि इस लेटरल वॉल में प्रेजेंट है तो दिस इज क्लिनिकली इंपॉर्टेंट. Another thing which is important in the nasal cavity is this lips area or the nasal batch जिसको कहते हैं area. और ये क्यों important है? This is important because एक्सेस जो है वो एक क्लिनिकल कंडीशन है जैसे ब्लीडिंग फ्रॉम द नोज वो जो है उसकी वजह से इंपॉर्टेंट है और ये होती है अगेन ऑन द लेटरल ऑफ द नोज बिकॉज ये हाईली वेस्कुलर रीजन ऑफ द नोज होता है और इसमें जो है वो कौन कौन सी वेसल्स जो है वो कंट्रीब्यूट करती हैं इस लिटल्स एरिया में. तो वी हैव एंटीरियर एथमोइडल आर्टरी व्हिच इज अ ब्रांच ऑफ ऑप्थैल्मिक आर्टरी वो इसमें पार्टिसिपेट करती है. देन वी हैव दिस then we have the branches from the maxillary artery which are sphenopalatine branches. We have greater palatine branches and we have direct branches from the facial artery. Facial artery से आपके पास superior labial artery then septal branches आती हैं. तो important thing is कि MCQ में अगर आपसे पूछा जाए कि internal carotid artery की कौन सी branch जो है वो contribute करती है ophthalmic artery की कौन सी ब्रांच कंट्रीब्यूट करती है. स्फेनोपैलेटाइन के साथ आपके बहुत सारे एमसीक्यूज मैंने देखे हैं कि लिटल्स एरिया में जो है वो आपके वेस्कुलर सप्लाई जो है वो किन वेसल से आती है तो आपको इन वेसल्स के ओरिजिन जो है वो पता होना चाहिए. सो वी हैव anterior ethmoidal arteries from ophthalmic. We have sphenopalatine arteries, we have greater palatine arteries from maxillary, and we have septal branches of the facial artery. तो ये हैं सारे के सारे जो कंट्रीब्यूट करते हैं केजल बैच एरिया में या लिटल्स एरिया में. Then we have this orbital cavity. Orbital cavity जो है वो आप देखें orbital cavity is basically orbital cavity has a medial wall, we have a lateral wall, we have a roof and we have a floor. और ये सारे के सारे जो हैं ये कौन बना रहे हैं? ये हमारे पास जो है वो skull bones जो है वो बना रही हैं. So medial wall of the orbital cavity is formed from posterior to anterior by the sphenoid bone. We have orbital plate of the ethmoid bone, we have lacrimal bone, we have frontal process of the maxilla. So all these bones makes up this medial wall. Then floor of the orbit is formed by the orbital process of the palatine bones. We have orbital surface of the maxillary bone and we have this zygomatic bone that makes the floor of the orbit. Then we have this lateral wall of the orbit. Lateral wall of the orbit is formed by the zygomatic process of the frontal bone. We have this zygomatic process of the bone. और उसके अलावा जो है वो अगर हम इंटीरियर ऑफ द ऑर्बिट देखें तो वी हैव दिस पिंक कलर ग्रेटर विंग ऑफ स्फेनॉइड बोन जो आपको यहाँ पे नजर आ रहा है. तो ये तीन बोन्स जो हैं ये मिलके आपका लेटरल वॉल ऑफ द ऑर्बिट बनाते हैं. देन रूफ ऑफ द ऑर्बिट इज फॉर्म्ड बाय द लेसर विंग ऑफ द स्फेनॉइड एंड द ऑर्बिटल प्लेट ऑफ द फ्रंटल बोन. Now, the movement. Muscles of the eye are divided into basically two groups. We have intraocular muscles and we have extraocular muscles. Intraocular muscles includes the ciliary muscles जो कि आपके जो है वो होते हैं. उसके अलावा जो है वो आपके pupillary muscles होते हैं जो pupil के साथ associated होते हैं. तो वो आपके आ जाते हैं intraocular muscle group में. And they are connected with the ciliary ganglion जिसके बारे में हमने अभी बात की थी पैरासिम्पैथेटिक गैंग्लियन के साथ. Now, the extraocular muscles are basically the recti. We have 4 recti. These are superior rectus, we have medial rectus, we have inferior rectus, and we have lateral rectus. the movement of the eyeball is basically dependent upon these recti, and then we have the superior oblique and inferior oblique also. Lateral recti move the eye basically laterally, और दूसरी टर्म जो यूज होती है आपके एमसीक्यूज में जो मैंने देखा है, इट abducts the eye, यानी आपके मिड लाइन पोजीशन से उसको जो भी चीज दूर लेके जाएगी, that is called abduction. तो lateral rectus move eye laterally or abducts the eye. Medial rectus move eye medially or adduct the eye. Superior rectus basically elevates and turn it medially, यानी elevate करेगा और उसको medially turn करेगा, and then inferior rectus जो है वो उसको depress करेगा और उसको medially turn करेगा, और इनको oppose करने के लिए we have superior and inferior oblique muscles. Superior oblique muscle basically depresses the eye and turn it laterally opposite to the superior rectus, and inferior oblique basically elevates the eye and turn it laterally, usko laterally move karega. So these are the actions of all these muscles. अब important क्या है कि nerve supply कहाँ से आती है. अब इसमें भी जो है वो हम कहते हैं, आई थिंक आपने जो है वो LO4 SR6 के नाम से हम याद करते थे कि SO4 LR6, that is superior oblique, is supplied by the fourth cranial nerve, which is the trochlear nerve, and LR6 is basically the abducent nerve, that is lateral rectus, which is supplied by the abducent nerve, and then all other muscles of the eye are supplied by the oculomotor nerve. अब उसमें जो है वो उसकी superior and inferior division जो है ये further उसको अगर हम बहुत minute में जाएंगे तो हमें होगा कि superior division of the oculomotor nerve supplies the levator palpebrae, superior and superior recti, and inferior division basically medial rectus, inferior oblique, and inferior rectus. तो ये हो गया हमारे पास nerve supply of the extraocular muscles. अब palsy की सूरत में क्या होगा कि what happened if these nerves are damaged. These nerves means we have cranial nerve 3, which is the oculomotor nerve, and cranial nerve 4, which is the trochlear nerve, and cranial nerve 6, which is the abducent nerve. तो I think ये slide जो है वो आप इसको देख लें, आपको पता चलेगा कि palsy of the cranial nerve 3, which is supplied by the superior rectus, which supplies the superior rectus or innervates the superior rectus, medial rectus, inferior rectus, and inferior oblique. तो obviously action उन muscles के जो हैं वो effect होंगे. This is the normal eye. Sorry, this is the normal right eyes, or in case of cranial nerve 3 palsy क्या होगा कि lateral deviation होगा और ptosis और downward deviation होगा. In case of the fourth nerve palsy, if you can see, this is the right eye. हमने सिर्फ right eye को observe करना है, left is the normal one. तो इसमें जो है वो क्या होगा, upward deviation होगा, ठीक है. In case of abducent nerve जो है इसमें medial deviation होगा. Obviously muscles जो nerves muscles को innervate कर रही हैं उनके actions, और वो last slide में जैसे बताया वो आपको पता हो तो आप इसको assess कर सकते हैं. Now coming to the oral cavity. Oral cavity is basically inferior to the nasal cavities. It separate from them by a hard and soft palate. Floor of the oral cavity, soft tissues सारे के सारे बना रहे हैं. Anterior opening to the oral cavity is the oral fissure, and posterior opening is the oropharyngeal isthmus. In the oral cavity हमने टंग के बारे में पहले बात कर ली है, हमने पैलेट के बारे में पहले बात कर ली है. तो we have glands which are minor and major salivary glands के बारे में बात करेंगे. Minor salivary glands जो हैं वो basically these are smaller, these are more numerous than the major salivary glands. यहाँ पे आपको नजर आ रहे हैं. They are scattered in the tissues of buccal, labial, and lingual mucosa, the soft palate, lateral portion of the hard palate, and the floor of the mouth. Von Ebner's gland जो हैं वो present होते हैं at the posterior 1/3 of the tongue पे. So these glands are associated with large circumvallate papilla on the tongue. So these are minor salivary glands. Then we have the major salivary glands. Major salivary glands are basically the parotid gland, the submandibular gland, and the sublingual gland, which are present in the oral cavity. पैरोटिड ग्लैंड की बात करें तो पैरोटिड ग्लैंड जो है that is present on the side of the face and saliva pass from parotid gland into the mouth through a duct which is called the parotid duct. अब इसमें इम्पोर्टेंट इज जो मैंने आपके पास्ट एमसीक्यूज में देखा है कि आपको डक्ट्स एंड ओपनिंग ऑफ डक्ट इज वेरी इंपॉर्टेंट कि वो डक्ट्स ओपन कहाँ हो रही है. जैसे पैरोटिड डक्ट बेसिकली it opens opposite the second molar tooth and this duct is called Stenson's duct. तो आपको डक्ट का नाम और where it opens आपको उसकी ओपनिंग जो है वो पता होना जरूरी है. और दूसरी चीज जो इम्पोर्टेंट है पैरोटिड डक्ट को लेके कि इट बेसिकली रन्स ओवर द मैसेटर मसल एंड इट पियर्सेस द बक्सिनेटर मसल. ये एक सिंगल लाइन जो है दैट इज वेरी इंपॉर्टेंट कि कौन से मसल के ऊपर ये लाई करती है और कौन सी मसल को ये पियर्स करके ऑपोजिट द सेकंड मोलर टूथ जाती है. तो वी हैव मेसेटर एंड द बक्सिनेटर. तो ये दो चीजें आपको याद रखनी है यहाँ पे. Then we have this submandibular gland. Submandibular gland basically present here in the submandibular region and it release saliva into the oral cavity. ये आपको green duct नजर आएंगे. This is the submandibular duct which is called the Wharton's duct. And it ends in the sublingual caruncles जो यहाँ पे नजर आते हैं. This is sublingual gland that release saliva into the oral cavity through sublingual duct which is called the Bartholin's duct. तो again आपको ducts और उनकी openings के बारे में जो है वो यहाँ पे पता होना चाहिए. Now the region of the neck. Region of the neck हम define करते हैं कि the portion of the body joining the head to the shoulder and the chest is called the neck. तो कुछ important structures जो कि obviously हम हर चीज को जो है वो यहाँ पे आप नहीं कर सकते. तो important चीजें जो neck region की हैं I will discuss all these important or brief all these important topics. So we have some important structures that contained in or passing through the neck, and these structures are basically the seven cervical vertebrae, and that enclose the spinal cord. We have a muscle which is the sternocleidomastoid muscle and hyoid muscles in front. We have trapezius muscle, जो कि shoulder का muscle है, and other nuchal muscles behind. We have jugular veins, we have carotid arteries, we have part of esophagus, we have larynx, we have vocal cords. तो ये जितने structures हैं that makes up the region of the neck. Now, what important is basically the cutaneous innervation of the neck. First of all, अगर हम layer by layer जाएं तो we have skin, and then skin के साथ associated we have these cutaneous nerves. These cutaneous nerve comes from the sensory branches of the cervical plexus. Again, this is very important. They come from the cervical plexus, and cervical plexus से जो आती हैं हमारे पास, तो region wise अगर आप नाम देखें तो we have lesser occipital nerve, we have greater auricular nerve, we have transverse cervical nerve, we have supraclavicular nerve. So all these nerves are the sensory branches of the from cervical plexus, जो कि इस पूरे region को जो है cutaneous innervation देती हैं. अगर आप यहाँ पे territories देखें तो this is the territory of the face. अगर आपको याद हो sensory innervation of the head में हमने किया, तो this is the ophthalmic division of trigeminal, this is the maxillary, and this is the mandibular. और neck region में अगर आप देखें तो we have this we have this greater occipital nerve region, we have this lesser occipital nerve region, we have this greater auricular nerve, auricle के साथ associated अगर आप देखें, and we have this transverse cervical region. And जो हमारी बैक साइड होती है उसको posterior repair of the spinal nerves जो हैं they basically contribute in the cutaneous innervation posteriorly. अब यहाँ पे अगर आप देखोगे this is the posterior part of the head and neck. We have this greater occipital nerve. ठीक है, ये टेरिटरी अगर आप देखो तो इसके साथ इसको मैच करने की कोशिश करें आप, यहाँ तक जो है वो आपके ऑफ्थैल्मिक डिवीजन आएगी. देन वी हैव दिस ग्रेटर ऑस्पिटल नर्व, देन वी हैव दिस लेसर ऑस्पिटल नर्व रीजन, this, and we have on the posterior midline we have this third occipital nerve region. तो ये, and then all the posterior cutaneous nerves from the dorsal lemma of C4, C5 and C6. तो ये regions जो हैं वो आपको अगर picture memory आपकी अच्छी है तो most probably आपको याद रहेंगे. Then we have the superficial fascia of the neck. Superficial fascia is basically it is subcutaneous. It is present just below the skin, and it covers the platysma muscle, which is very important. And platysma muscle basically जो है वो आपके clavicular region से जो है वो origin होता है उसका, और आपका face में जो है वो zygomatic bones तक जो है वो जाके ये इसकी attachments होती हैं. फंक्शंस क्या हैं इस प्लेटिस्मा मसल के बेसिकली कि ये कवर करता है all the underlying structures. It basically depresses the mandible, it draws down the lower lip, it helps in release the pressure from the superficial vein. This is very important अगर हम इसके functions की बात करते हैं तो. And it is supplied by the cervical branches from the facial nerve. In case of paralysis of this muscle, skin basically fall away from the neck in slack folds. तो हमारी जो skin हमें smoothed out नजर आती है वो because of this platysma muscle. Then after this superficial fascia, we have deep fascia, which is very, very, very important clinical point of view से भी, और obviously इसका concept जो है वो अगर आपको होगा तो आपको आसान लगेगी हर चीज. बहुत सारे MCQs हैं जो हेड एंड नेक रीजन में हैं जो कि फोकस करते हैं हमारा डीप सर्वाइकल फेशिया को. तो डीप फेशिया is also called fascia colli, and it forms a collar around the neck. It lies deep to platysma muscle in the interval between muscles, vessels, and organs of the cervical region. It gives various extensions or lamina around various structures of the neck. We have got investing layer of deep cervical fascia, we have pretracheal layer, we have prevertebral layer, we have carotid sheath, and we have buccopharyngeal fascia and alar fascia. हम इसको one by one डिस्कस करते हैं और इसमें जो इम्पोर्टेंट क्लिनिकली इम्पोर्टेंट जो स्पेसेस और स्ट्रक्चर्स हैं हम उनको डिस्कस करेंगे. तो पहले एक छोटा सा ओवरव्यू के ये बेसिकली है क्या. दिस इज द ट्रांसवर्स सेक्शन ऑफ द नेक रीजन. आप यहाँ पे देखो तो आफ्टर स्किन एंड दिस प्लेटिस्मा मसल, दिस इज एंटीरियर, दिस इज पोस्टीरियर. तो आफ्टर स्किन एंड प्लेटिस्मा मसल वी हैव दिस रेड कलर, वी हैव सुपरफिशियल और इन्वेस्टिंग लेयर ऑफ डीप सर्वाइकल फेशिया, एंड दिस डीप cervical fascia basically surrounds this layer, basically surrounds the neck, and it encloses the sternocleidomastoid muscle which is present anteriorly, and we have this trapezius muscle. Thank you. This trapezius muscle posteriorly. So investing layer of deep cervical fascia basically encloses these muscles anteriorly and posteriorly. Then we have layer of pretracheal fascia. As the name suggests, pretrachea means in front of trachea. So in front of trachea we have thyroid gland. So pretracheal layer basically completely enclose this thyroid gland. So this is the pretracheal fascia. Then we have this buccopharyngeal fascia. Buccopharyngeal fascia basically present behind the esophagus, and it basically connect the two carotid sheaths जिनके बारे में भी हम बात करेंगे. This is the carotid sheath. Carotid sheath basically जो है again extension of deep cervical fascia है और ये enclose करता है आपके structures को जिसमें है हमारे पास common carotid artery, we have internal jugular vein, and we have vagus nerve. Then we have prevertebral fascia. Prevertebral fascia basically covers the cervical vertebra and the muscle which are attached with the vertebra. यानी prevertebral muscles को जो है ये सारा का सारा cover करता है. This is prevertebral fascia. And in front of या हम कह सकते हैं कि between the buccopharyngeal fascia and the prevertebral fascia is another layer of fascia which is called the alar fascia. इनके बारे में अब हम one by one जो है वो discuss करते जाते हैं along with the clinicals associated with these facial layers. Pretracheal layer. Why this pretracheal layer is important? First of all, इसके MCQs अगर आप देखें तो इसमें सबसे पहले जो है वो आपको thyroid के साथ associated आते हैं MCQs के. The layer of the deep cervical fascia that encloses the thyroid gland is pretracheal layer. It basically attached to the hyoid bone, and inferiorly it blend with the pericardium and arch of aorta, and it completely enclosed the thyroid gland. Clinically अगर देखें तो this fascia forms the outer capsule of the thyroid gland. Posterior part जो है, that is very thin. It is not well defined. So thyroid swelling, if grows posteriorly, so it compresses the esophagus and can cause dysphagia. तो clinical scenario को अगर आप थोड़ा सा imagine करें कि dysphagia के साथ patient है और thyroid swelling भी है, तो वो क्या उसमें जो है वो clinically चीजें important है. Then we have the thyroid gland basically moves with deglutition. अगर आप observe करो, तो posterior aspect of the gland is attached to the cricoid cartilage, or cricoid cartilage के साथ attached होता है thickening of this fascia, and this is called ligament of Berry or suspensory ligament of the thyroid gland. During thyroid surgeries, again scenarios के साथ मैंने MCQs देखे हैं कि during thyroid surgeries this ligament has to be cut to mobilize the gland. तो हम कहेंगे कि ligament of Berry or suspensory ligament is basically a thickening of the pretracheal layer of the deep cervical fascia, और उसको जो है वो mobilize करना जरूरी होता है during thyroid surgeries. Then continuity of this pretracheal layer अगर आप देखें तो ये basically extend करता है anterior mediastinum तक. तो infection in this area of this fascia ये extend करता है, आपका spread of infection होता है anterior mediastinum तक. Again, this is very important कि उसका extension जो है वो fascia का कहाँ तक होता है और उसमें जो spaces बनती हैं, again हम उसको discuss करते हैं, that is a pretracheal space कहलाती है वो. Then we have this prevertebral fascia. A prevertebral fascia, it extends from base of the skull up to the body of the third thoracic vertebra. यानी आप देखो तो इसका extension कितना ज़्यादा है due to extension. और दूसरी चीज़ ये कि it continues with the axillary sheath. So obviously infection in the prevertebral region, which is जिसमें infection में tuberculosis of the vertebra हो सकता है, may lead to spread of pus to the axillary region. और again अगर वहाँ पे है तो lymph node में जो है वो enlarge हो सकते हैं, abscess हो सकती है posterior triangle of the neck में, क्योंकि वहाँ से जो है वो ये pierce करती हैं इसके बहुत से nerves और structures. Prevertebral fascia forms the posterior wall of the retropharyngeal space. ये क्या है retropharyngeal space, इसको हम अभी discuss करते हैं. आपके जो oropharyngeal opening है, this is oral cavity and this is pharynx. Oropharyngeal opening में आपको जो posteriorly wall नजर आती है pharynx की, वहाँ पे ये space है, and that is present between the prevertebral fascia and the buccopharyngeal fascia. So this is the buccopharyngeal fascia and this is the prevertebral layer. So this space is present between these two cervical facial layers, और ये जो है ये extend करती है again जो आपके ये layer है ये extend करती है mediastinum तक. तो again infection इस area में जो भी होगा वो आपका mediastinum तक या thoracic cavity तक जो है वो extend करेगा. Now, other spaces जो important हैं, हमने बात की pretracheal space की, तो we have also carotid space. This is the pretracheal space जिसके बारे में हमने बात की कि उसमें infection अगर होगा तो that extend up to the anterior mediastinum. Carotid sheath के साथ जो होगा obviously वो भी superior mediastinum तक होगा. Then we have these facial spaces which is called the retropharyngeal space. This is buccopharyngeal fascia and this is the buccopharyngeal fascia and this is the alar fascia. And this is the prevertebral layer. अगर आप यहाँ पे देखो तो ये buccopharyngeal layer है, ये आपकी prevertebral है, in between the two is the alar. तो alar और buccopharyngeal के दरमियान में जो space है that is called retropharyngeal space, और alar fascia और prevertebral के दरमियान जो space है that is called the danger space. So this is the danger space and this is the, अब इसमें जो है वो आपको जो याद रखना है और जो important है कि इनकी layers के किन दो layers के दरमियान में कौन सी space है और वो space जो है वो कहाँ तक extend करती है, वो important है. अब कैरोटिड शीथ जैसे हमने उसके बारे में बात की, इट इज फॉर्म्ड एंटीरियरली बाय प्रीट्रेकियल लेयर और पोस्टीरियरली बाय प्रीवर्टिब्रल, और इसके कंटेंट्स हैं इंटरनल जुगुलर वेन, कॉमन कैरोटिड आर्टरी एंड वेगस नर्व। Buccopharyngeal fascia, उसके बारे में भी हमने किया, it is posterior to the esophagus and separate the esophagus from the cervical vertebra. तो उसके दरमियान में जो है वो आपको स्पेस जो प्रेजेंट होगी बिटवीन अलार एंड बक्कोफेरेंजियल इज कॉल्ड रेट्रोफेरेंजियल। अलार यहाँ पे अगर आप देखो तो आपको क्लियरली विजिबल है, this is esophagus, this is buccopharyngeal, and this is prevertebral. In between the two is alar. Space in front of alar is retropharyngeal. Behind the alar fascia is the danger space. Why it is called the danger space? ये हमने डिस्कस कर लिया. It extends from skull to the base of diaphragm. This red space is basically the danger zone of the deep cervical fascia, या हम जो cervical spaces करते हैं. तो basically this danger space extends from the base of the skull up to the diaphragm. तो infection पूरे neck region में आपके जो भी होगा that extend up to the diaphragm. तो इसलिए इसको हम danger space कहते हैं. Now coming to the triangles of the neck. We have the side of the neck is the lower border of the body of the mandible. Below is the upper border of the clavicle. Posteriorly अगर हम देखें तो we have anterior border of the trapezius muscle, and anteriorly देखें तो we have midline of the neck. तो ये quadrilateral space बनती है जिसकी further division होती है into the triangles. कैसे? We have sternocleidomastoid muscle. This is the muscle that divides the neck into different regions. We have anterior and we have posterior regions. और triangular shape होते हैं तो हम कहते हैं इनको कि these are triangles. We have anterior triangles and posterior triangles. Sternocleidomastoid, it has a sternal head and clavicular part, sternal part and clavicular part, and it is attached to the mastoid process. So a nerve supply of this muscle is basically the accessory nerve. Anterior triangles की अगर हम बात करते हैं तो we have on the midline. अब anterior triangle की boundaries को अगर हम देखते हैं तो medially we have midline of the neck, laterally we have anterior border of the sternocleidomastoid, and superiorly we have the base of the mandible जिसको हम कह सकते हैं. तो ये हमारा एक major triangle जो कि anterior triangle बना, that is further divided into 4 different triangles. We have submental triangle. अगर आप mental से याद रखो chin areas जो है वहां से, तो this is submental triangle. Below the chin, we have side of the submental is the digastric region or digastric triangle. We have a carotid triangle, and we have this muscular triangle. When we talk about submental triangle की अगर हम boundaries देखें तो medially it is bounded by the midline. Laterally we have the medial border of या हम कह सकते हैं कि anterior belly of the digastric muscle, and below we have this hyoid bone. तो सबमेंटल ट्रायंगल की जो है वो सबसे इम्पोर्टेंट चीज जो इसके कंटेंट्स में है, these are submental lymph nodes. अगर आपको याद हो तो अभी हमने किया कि टिप ऑफ द टंग जो है that drains into the submental lymph nodes. Then we have this digastric triangle. Digastric triangle is bounded superiorly by the mandible, medially by the anterior belly of the digastric, inferiorly by the posterior belly of the digastric. And this digastric triangle houses the submandibular gland. We have a facial artery, facial vein pass through this. And we have nerves and vessels to this mylohyoid muscle. This is mylohyoid. हमने floor of the mouth में देखा था. This muscle is mylohyoid muscles. तो nerves and vessels to the mylohyoid यहाँ जाएंगे. We have submandibular lymph nodes जो हैं वो group यहाँ पे present होगा. We have external carotid artery, carotid triangle से pass होके digastric triangle में आएगी. So all these structures are present in this digastric triangle. Then we have this carotid triangle, as the name suggests. Carotid triangle में जो है वो आपकी carotid sheath along with its contents होना चाहिए, and उसके contents में है we have common carotid artery, we have external and internal divisions of the carotid artery, we have internal jugular vein, we have vagus nerve, and along with the vagus nerve we also have the other cranial nerves which are vagus. Vagus है, उसके अलावा जो है वो accessory nerve है, we have a hypoglossal nerve. So all these cranial nerves are also present in this carotid triangle or pass through this carotid triangle. Then we have this muscular triangle, and a muscular triangle basically नाम से पता चलता है कि that is made up of the infrahyoid muscles जो हमें यहाँ पे नजर आ रहे हैं. तो यहाँ पे जो है वो muscles हैं, और उसके अलावा जो है वो deep to this muscular triangle are very important structures. These are basically larynx, trachea, we have thyroid, we have esophagus. तो वो deep structures of this triangles जो है उसमें हम include करते हैं. Then anterior triangles के बाद we have posterior triangles. Posterior triangles जो है वो क्या है कि उसकी boundaries में अगर आप देखो तो posterior triangle is bounded anteriorly by the posterior border of the sternocleidomastoid. We have posteriorly the anterior border of the trapezius muscle. Inferiorly we have the clavicle. और ये पूरा posterior triangle जो है वो that is very important because इसमें जो है वो इसका floor जो है, अगर कोई भी triangle देखें तो उसमें roof is formed by the skin and the subcutaneous tissue and the cervical fascia, and the floor is formed by the muscle. अब इसमें जो muscle important हैं जो आपके MCQs में पूछे जाते हैं कि floor of the posterior triangle is formed by the splenius capitis. अगर आप यहाँ पे ऊपर से नीचे की तरफ आएं तो we have splenius capitis, we have levator scapulae, we have anterior scalene, middle scalene, and the trapezius muscle. तो ये सारे के सारे, and we have the inferior valley of the omohyoid muscle that divides the posterior triangle into two parts. We have occipital triangle and clavicular part. तो ये है, और इसके साथ जो है वो contents जो है अगर हम देखें तो contents of the posterior triangle are basically the यहाँ पे अगर आप देखोगे तो we have अगर vessels की बात करें तो we have third part of the subclavian artery, we have transverse cervical artery. This is the transverse cervical artery. We have suprascapular arteries. Suprascapular arteries. We have internal jugular vein. आपको जो है वो यहाँ पे part नजर आ रहा है. We have external jugular vein and its tributaries होंगी. और यहाँ पे जो नजर आ रहा है, this is the brachial plexus. Brachial plexus जो है वो उसके cords आपको मिलेंगे. We have spinal part of the accessory nerves जो यहाँ पे आप देख सकते हैं. This is the spinal part of the accessory nerve. और उसके अलावा जो है वो हमारे पास lymph node के ग्रुप्स होंगे जिसमें supraclavicular lymph nodes होंगे और occipital lymph nodes होंगे जो कि इस रीजन में जो है वो प्रेजेंट होंगे. तो ट्रायंगल्स के अगर आप कंटेंट्स देख ले तो आई थिंक दिस इज इनफ फॉर यू. अब क्लिनिकल कंडीशंस एसोसिएटेड विद दीज ट्रायंगल्स जो हैं वो अगर देखें तो वी हैव अ क्लिनिकल कंडीशन व्हिच इज कॉल्ड द टॉर्टिकुलस. टॉर्टिकुलस में क्या होता है कि वन साइड ऑफ द sternocleidomastoid becomes short while the other side of the muscle is stretched. और उसकी वजह से क्या होगा कि ऑब्वियसली जो शॉर्ट होगा तो आपका हेड जो है वो टिल्ट करेगा एंड ऑन वन साइड एंड इट इज डिप्रेस्ड, एंड दिस इज ड्यू टू स्पैज्म ऑफ द कॉन्ट्रैक्चर ऑफ द मसल. और इसमें जो आपकी नर्व इन्वॉल्व होती है, ऑब्वियसली दिस मसल इज सप्लाइड बाय द एक्सेसरी नर्व, तो स्पाइनल पार्ट ऑफ द एक्सेसरी नर्व. तो ये क्लिनिकल कंडीशन जो है वो इसके साथ एसोसिएटेड है, स्पाइनल पार्ट ऑफ द एक्सेसरी नर्व एंड द sternocleidomastoid muscle. Then we have the congenital torticollis. This is called dry neck. Again, इसके साथ MCQ मैंने देखे थे इसलिए मैंने इसको include किया. तो it is a twisting of the neck that causes the head to rotate and tilt at an odd angle. तो ये अमूमन जो है वो congenital condition है और obviously associated with the sternocleidomastoid. तो उसकी nerve जो है वो इसके साथ भी जो है वो involved होगी. बाकी जो है वो अगर क्लिनिकल कोरिलेट्स देखें तो वी हैव एक्सेसरी नर्व मे बी डैमेज क्योंकि वो जो है वो सुपरफिशियल है. जब हम लिम्फ नोड बायोप्सी लेते हैं नेक से तो एक्सेसरी नर्व डैमेज हो सकती है. वी हैव एक्सटर्नल जुगुलर वेन व्हिच इज वेरी सुपरफिशियल हियर, सो दिस मेक्स इट वल्नरेबल टू इंजरीज. ना इम्पॉर्टेंट ये मैंने इंक्लूड इसलिए किया क्योंकि मैंने बहुत सारे एमसीक्यूज देखे हैं जो इसकी ब्लड सप्लाई और नर्व सप्लाई को लेके जो है वो है कि थायराइड सर्जरी हुई सिनेरियो बेस्ड, तो उसमें जो है वो कौन सी नर्व डैमेज हुई और कौन सी वेसल जो है वो उसको हमने स्पेयर किया। तो thyroid and parathyroid gland, these are basically posterior side of the thyroid gland consist of these parathyroid group of glands, which are two or paired superior parathyroid glands and inferior parathyroid glands. Superior parathyroid and inferior parathyroid blood supply from blood supply or arterial supply जो है that comes from directly from the ब्रेकियोसेफेलिक ट्रंक। ब्रेकियोसेफेलिक ट्रंक से जो है वो हमारे पास इंफीरियर थायराइड आर्टरी आती है जो कि इंफीरियर पार्ट ऑफ द थायराइड ग्लैंड को जो है वो ब्लड सप्लाई करती है। एंड वी हैव सुपीरियर थायराइड आर्टरीज। सुपीरियर थायराइड आर्टरी अगर आपको याद हो तो इट डायरेक्टली कम फ्रॉम द एक्सटर्नल कैरोटिड आर्टरी। ठीक है, तो एक्सटर्नल कैरोटिड आर्टरी से डायरेक्टली आएगी सुपीरियर थायराइड आर्टरी, और सुपीरियर थायराइड आर्टरी जो है वो आपका सुपीरियर लोब ऑफ द थायराइड ग्लैंड को जो है वो ब्लड सप्लाई करेगी। अगेन वेन्स जो है वो उसी के साथ एसोसिएटेड है कि these are inferior thyroid veins जो कि डायरेक्टली ड्रेन होंगे into the brachiocephalic veins, और इसी तरह से जो है वो इंफीरियर जो है वो यहाँ पे ड्रेन होंगे और सुपीरियर जो है ऑब्वियसली वो होंगे जगुलर्स के अंदर। ठीक है, तो ये है इसकी ब्लड सप्लाई। और नर्व सप्लाई में जो है वो अगर आप देखो तो upper part of the thyroid gland जो है वो that is supplied by the superior laryngeal nerve। ठीक है, superior laryngeal nerve, and lower part जो है वो that is supplied by the recurrent laryngeal nerve। तो हमने जब स्पेयर करना होता है तो यानी थायराइड सर्जरीज में तो अगर अपर लोब और लोअर लोब की डिवीजन होगी तो उसमें नर्व सप्लाई आपको याद रखनी है। और इन केस ऑफ ब्लड सप्लाई जो है कि सुपीरियर थायराइड आर्टरी इज द ब्रांच ऑफ विच आर्टरी, इट कम्स डायरेक्टली फ्रॉम द एक्सटर्नल कैरोटिड आर्टरी, एंड इंफीरियर थायराइड जो है दैट कम्स डायरेक्टली फ्रॉम द ब्रेकियोसेफेलिक ट्रंक। तो मतलब ये सारी बातें जो है वो आपको इसमें याद रखनी है। देन व्हाट इज फेरिंक्स? इंशाल्लाह हो जाए। ट्यूब, फाइब्रोमस्कुलर ट्यूब में जो है वो क्या है, इट इज लोकेटेड बिहाइंड द कैविटीज ऑफ नोज, माउथ एंड द larynx, and it extends from the base of the skull to the esophagus, and it is divided into nasopharynx, oropharynx and laryngopharynx। यानी इसके तीन पार्ट्स जो हैं वो pharynx के होंगे। Pharyngeal fascia, which is important, it is separated into two layers, and pharyngeal muscles basically sandwich between the two layers. The first layer is the buccopharyngeal fascia, और second layer is the pharyngobasilar fascia। ठीक है, ये उसकी अटैचमेंट के हिसाब से जो है वो इनके नाम है। तो we have two layers of fascia, और in between these two layers are present the pharyngeal muscles। तो we have buccopharyngeal fascia and pharyngobasilar fascia, और बाहर वाली लेयर जो है वो outer layer is the buccopharyngeal, and inner outer layer is the buccopharyngeal and inner layer is the pharyngobasilar, and it basically reinforces the pharyngeal wall। Then comes the pharyngeal muscles। अब pharyngeal muscles जो हैं वो basically divided into two main groups। We have longitudinal muscles and we have circular muscles, and all these are basically skeletal muscles। तो longitudinal muscles की बात करें, obviously direction of the fibers जो है ये आपको बताता है कि muscle जो है वो किस तरह के हैं। longitudinally arranged muscle fibers जो हैं, these are stylopharynges, that stylopharynges जो कि pharynx को connect करता है with the styloid process। Then we have salpingopharynges, and salpingopharynges हो गया। Then we have palatopharynges। तो palatopharynges, this is the palatopharynges muscle, this is the salpingopharynges, this is the stylopharynges, and this। और इसमें जो है वो क्या है कि कभी भी मसल्स करें तो अगर ये लॉन्गिट्यूडनल है तो ऑब्वियसली क्या करेंगे, बेसिकली ये शॉर्टनिंग करेंगे अपवर्ड मूव करेंगे तो ये डेग्लूटेशन में जो है वो बेसिकली हेल्प करेगा ये सारा का सारा. They are attached to the posterior border of the thyroid cartilage, and they help in the second stage of deglutition by lifting the pharynx. और इसी तरीके से जब हम सर्कुलर मसल्स की बात करते हैं जिनको हम कॉन्स्ट्रिक्टर्स कहते हैं, तो कॉन्स्ट्रिक्टर्स का काम जो है वो क्या होगा कि वो प्रोपेल करने की कोशिश करेंगे, लॉन्गिट्यूडनल शॉर्टनिंग करेंगे, डेग्लूटेशन में हेल्प करेंगे, और ये जो है ये प्रोपेल करने में जो है वो हेल्प करेंगे. So we have three groups of constrictors. We have superior constrictor, we have these middle constrictors, and we have these inferior constrictors. Middle constrictors and inferior constrictors, and all these are incomplete anteriorly, and they are arranged in three layers which overlap each other. तो इनकी functioning भी जो है वो उसके हिसाब से होगी. अब दिस स्लाइड इज वेरी इंपॉर्टेंट, लेकिन आपको इसको जो है वो देखना पड़ेगा क्योंकि याद करने के लिए जो है वो बहुत डिफिकल्ट है. बट बिटवीन द सुपीरियर एंड मिडिल कॉन्स्ट्रिक्टर्स कौन से स्ट्रक्चर्स जो है वो पास होते हैं, बिटवीन द मिडिल एंड इंफीरियर कॉन्स्ट्रिक्टर्स कौन से स्ट्रक्चर्स पास होते हैं, तो ये सारी की सारी चीजें जो हैं ये बहुत इंपॉर्टेंट है. एंड बिलो द इंफीरियर कॉन्स्ट्रिक्टर्स एंड पासिंग अपवर्ड्स आर द स्ट्रक्चर्स, कौन से स्ट्रक्चर्स होते हैं. तो दिस इज वेरी इंपॉर्टेंट. इसको आपके पास जो है वो हमारी प्रेजेंटेशन शेयर हो जाएगी, तो आप इसको गो थ्रू कर लीजिएगा कि कौन कौन से स्ट्रक्चर्स हैं. Then we have the blood supply of the pharynx. Blood supply of the pharynx जो है इसमें अगर देखें तो we have this common carotid artery, and common carotid artery then gives off internal and external carotid arteries. तो mostly जो है वो branches जो हैं वो आपकी जो pharyngeal wall को जाती हैं, these are from external carotid artery, जिसमें lingual artery आ जाती है. We have this ascending pharyngeal branch. तो ये सारी की सारी branches जो हैं, we have this ascending palatine artery, we have maxillary artery. तो ये सारी की सारी branches जो हैं वो areas को जो है वो pharyngeal areas को जो है वो supply करेंगी. इसी तरीके से जो है वो venous drainage भी जो है वो है कि all the venous blood जो है वो that drains into the internal jugular vein. तो इसके different जो है वो channels हैं. Now coming to the larynx, larynx actually बहुत important है. मैं इसको discuss करना चाह रही थी अपने respiratory system की जो है वो क्लास के साथ. मेरा ख्याल है इस वक्त तो हम सिर्फ brief सा एक इसका overview लेते हैं, तो I will discuss it in my next class जो कि है respiratory system की. तो अभी हम सिर्फ और सिर्फ जो है वो इसका brief सा overview जो है वो लेते हैं कि we have laryngeal cartilages which are paired and unpaired. Larynx is basically the sound box. We have unpaired cartilages which are epiglottis, and we have this thyroid cartilage, large thyroid cartilage. This is unpaired, and we have this cricoid cartilage which is unpaired cartilage of the larynx. And then we have these paired cartilages which are cuneiform cartilage. We have corniculate cartilage. We have arytenoid cartilage. तो ये सारे के सारे cartilages जो हैं, they makes up the laryngeal skeleton basically. Muscles of the larynx are further divided into extrinsic and intrinsic group of muscles. We have extrinsic muscles, again जो बाहर की तरफ से जो है वो आपकी elevation और depression जो है वो करते हैं. तो these muscles are basically suprahyoid muscles, and we have these infrahyoid muscles. Suprahyoid muscles, basically these are the digastric muscles. We have the mylohyoid muscles. We have these geniohyoid muscles. We have stylohyoid muscles. तो ये सारे के सारे muscles जो हैं, these are called the suprahyoid muscles. And we also have these infrahyoid muscles. Infrahyoid muscles are basically the sternohyoid. We have omohyoid, and we have this sternothyroid muscle. तो ये सारे के सारे जो हैं ये आपके infrahyoid muscle हैं. और अगेन जो बात मैंने पहले भी कही कि मसल्स के जो हैं वो अगर आप फाइबर्स की डायरेक्शन देखेंगे और आपका जो है वो आपको अंदाजा होगा कि ये मसल जो है वो कौन सा फंक्शन जो है वो परफॉर्म करता है. तो सुप्राहाइड मसल्स बेसिकली दे एलिवेट द मैंडिबल, बेसिकली ये अपवर्ड मूवमेंट्स के लिए हैं, और इंफ्राहाइड मसल्स जो बेसिकली ये पुल करते हैं. तो ओपनिंग और वो सारी चीजें जो है वो इनके साथ एसोसिएटेड होंगी. Extrinsic muscle के साथ we have intrinsic muscles of the larynx, and these muscles are basically the arytenoids. We have thyroarytenoid muscles, we have oblique arytenoid muscles, and we have the cricoarytenoids. We have the callus muscle जो कि vocal cords में होते हैं. तो ये सारे के सारे muscles जो हैं, these are intrinsic muscles of the larynx, जो कि इंशाल्लाह हम इसको जो है वो डिटेल में डिस्कस करेंगे कि कैसे फंक्शन करते हैं. Then we have this blood supply of the larynx. Blood supply जो है वो हमारे पास आती है inferior laryngeal arteries, and we have superior laryngeal arteries. Superior laryngeal arteries जो है वो basically superior thyroid artery, जब वो external carotid artery से निकलती है तो वो एक branch देती है which is called the superior laryngeal artery. So this is the superior laryngeal artery and this is a inferior laryngeal artery. And again veins जो है वो same आपके जो है वो drain होती है directly into the internal jugular veins. And we have these nerves also. शायद nerves की जो है, this is the nerve supply of the larynx. Nerve supply of the larynx is basically from the superior laryngeal nerve and inferior laryngeal nerve, which is called the recurrent laryngeal nerve. Again, क्योंकि motor nerve supply, यानी all the muscles of the larynx जो हैं, these are supplied by the this recurrent laryngeal nerve. Except cricothyroid muscle, ये एक statement होती है कि all the muscles of the larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by the external branch of superior laryngeal nerve. ठीक है. अब इसमें भी जो है वो हमारे पास sensory and motor division of the nerve supply होती है. तो we have sensory nerve supply जो जाएगी हमारी internal branch of the superior laryngeal nerve above the vocal cord. ठीक है. Above the vocal cord, sensory nerve supply of the larynx is through superior laryngeal nerve, internal branch of the superior laryngeal nerve, and below the vocal cord is sensory innervation जो है, that is by recurrent laryngeal nerve. जब हम motor nerve supply की बात करते हैं तो all the muscles of the larynx are supplied by the recurrent laryngeal nerve except the cricothyroid muscle, which is supplied by the external branch of the superior laryngeal nerve. Again, this is the internal branch. ठीक है. तो ये above ये आपको करेगा, these are sensory branches. ये cut section है, inside है. तो sensory above the vocal cord जो है, these are supplied by the internal branch, and below the vocal cord जो है, recurrent laryngeal nerve जो है वो आपके sensory innervation भी देगा. अब हमारे कुछ MCQs हैं. I think इनको देखते हैं. माइक ओपन करेंगे. मैं रीड करूं, आप आंसर करेंगे.
मिडिल मेनिंजियल आर्टरी.
और एक और चीज कि मैंने ये जितने MCQs यहाँ पे लिए हैं वो सारे के सारे आपके पास्ट पेपर्स में से हैं. जस्ट आपको ये बताने के लिए कि जितना भी हमने आज कोर्स कवर किया है वो बेसिकली वो टॉपिक्स हैं जो कि आपके MCQ पॉइंट ऑफ व्यू से इम्पोर्टेंट है. अदरवाइज जो है वो हेड एंड नेक रीजन इतना वास्ट रीजन है कि उसको जो है वो 2 hours में कवर करना इज नॉट पॉसिबल. ठीक है. तो हम ये करते हैं. Man suffers fracture of skull at the site of pterion. Which vessel is likely to be damaged?
Middle meningeal artery.
Middle meningeal artery. And middle meningeal artery is the branch of
maxillary artery.
Maxillary artery. Good. A sharp instrument passing through the superior orbital fissure would most likely to sever the following nerve. अब हम superior orbital fissure के contents पे जाएं. वहाँ पे important nerves थे.
Optic nerve.
बेटे optic nerve तो optic canal से आ रही थी.
Abducent nerve.
Abducent nerve is the correct answer, which is the 6th cranial nerve. तो अगर हम याद करें तो we have first cranial nerve from the cribriform plate, second cranial nerve which is the optic nerve from the optic canal. We have 3rd, 4th, 5th and 6th cranial nerve. ठीक है. These are from the superior orbital fissure. ठीक है. अब जो 5th cranial nerve है उसकी branches में civic division जो है वो हमारी पास होती है superior orbital fissure से. ठीक है. तो हमारे फेशियल नर्व, ये तो हमारा ऑप्शन वैसे ही हमने इसको निकाल दिया. देन वी हैव मैक्सिलरी एंड मैंडिबुलर. नहीं, फिफ्थ क्रेनियल नर्व की ऑफ्थैल्मिक ब्रांच यहाँ से पास होती है, तो वो हमारे ऑप्शंस में नहीं है. और ऑप्टिक नर्व जो है वो ऑप्टिक कैनाल से आएगी. तो एब्ड्यूसिव नर्व इज द करेक्ट आंसर. देन इसको रीड करें.
Structures passing through foramen ovale including all of the following except lesser petrosal nerve, B mandibular nerve, C middle meningeal artery, D accessory meningeal artery, and E option is an emissary vein.
हाँ जी, तो क्या आपको
Emissary
क्या
vein.
लगता है? एमिशरी वेन्स. एमिशरी वेन्स कौन सी वेन्स हैं? एमिशरी वेन्स आर द वेन्स जो कि आपके
the scalp.
हाँ, स्कैल्प और सुपरफिशियल पार्ट ऑफ द स्कल को कनेक्ट करती हैं विद द ड्यूरल वीनस साइनसेस. ठीक है. A man presented with a complaint of deafness on cells and mastoid tantrum has been severed. What blood vessel? तो आप सात के हिसाब से था. तो आपको कौन सा लगती है आर्टरी के?
Posterior auricular.
Auricular artery, A.
पोस्टीरियर ऑरिकुलर. आप अगर मेस्टॉइड देखते हैं जो है वो उसके एरिया के हिसाब से होगा. ठीक है. तो पोस्टीरियर ऑरिकुलर इज द करेक्ट आंसर. देन कंसर्निंग लिटिल्स एरिया, बेटे आप देखें, आंसर दें. लिटिल्स एरिया में कौन सी वेसल्स जो हैं वो कंट्रीब्यूट कर रही थी, अगर आपको याद हो तो इन स्टेटमेंट्स में से देखें कि कौन सी इनकरेक्ट स्टेटमेंट है. कैसलबैश प्लैक्सिस
Anastomosis between internal and external carotid arteries.
बिल्कुल गुड. बाकी सारे के सारे जो हैं वो हमारे लेबियल आर्टरीज भी थी, स्फेनोपेलेटाइन आर्टरीज भी थी. हमारा नेजल सेप्टम जो है वो उसका एंटीरियर इंफीरियर पोर्शन था. कैसलबैश प्लैक्सिस था, एंड दिस इज अ कॉमन साइट ऑफ एपिस्टेक्सिस. तो एनास्टोमोसिस जो है, दिस इज द राइट आंसर. ठीक है. नेजोलैक्रिमल डक्ट ड्रेन इनटू द लेटरल वॉल ऑफ द नेजल कैविटी की जब हमने बात की थी तो मियाटिस देखे थे, तो हमारे पास था कि ये कहाँ जो है
Inferior meatus.
inferior meatus of the nose. Good. Now, 34-year-old male presented to our surgeon with a swelling on tip of the tongue. On clinical examination, which lymph node group will be palpable? ये मैंने बहुत दफा बात की है आज.
Submental.
Submental lymph
Submental.
node.
Submental.
ठीक है. दिस इज वेरी इंपॉर्टेंट. इसी तरीके से जो है वो टंग की नर्व सप्लाई, सेंसरी एंड मोटर, बोथ आर वेरी इंपॉर्टेंट. A medical student is studying the posterior triangle of the neck in a cadaver specimen. She is likely to find all the following except a posterior triangle में कौन कौन से स्ट्रक्चर्स थे? हमारा मस्कुलर फ्लोर था.
Trunk of
हमारे-
brachial plexus.
Contain brachial
Contain supraclavicular nerve.
नहीं, ये सारी की सारी सुप्राक्लैविकुलर नर्व जो है वो उसकी कुटेनियस इनोवेशन थी. ट्रांसवर्स सर्वाइकल आर्टरी वहां से पास हो रही थी. पोस्टीरियर ट्रायंगल जो है दैट इज डिवाइडेड बाय inferior belly of the omohyoid. तो यहाँ पे हमारे ऑप्शंस में है, तो दिस इज द इनकरेक्ट आंसर. अदरवाइज उसके कंटेंट्स को अगर आप देखो तो उसमें जो है वो स्पाइनल एक्सेसरी नर्व थी, ट्रंक्स ऑफ ब्रेकियल प्लेक्सस थे, सुप्राक्लैविकुलर जो सेंसरी ब्रांचेस थी वो सब थी. वी हैव ट्रांसवर्स सर्वाइकल आर्टरी. ये सारे के सारे जो है वो कंटेंट्स ऑफ द पोस्टीरियर ट्रायंगल थे. नेक्स्ट वी हैव अ मैन प्रेजेंटेड विद द swelling presented the swelling on neck. Swelling was present in front of pretracheal fascia. The most likely site for a spread of infection is
Anterior mediastinum.
Anterior
mediastinum, because pretracheal space extend up to the anterior mediastinum. जो retropharyngeal space है that extend up to the posterior mediastinum. जो danger space है that extend up to the diaphragm. ये याद रहेगा आपको?
मैम एक दफा रिपीट कीजिएगा काइंडली।
बेटे मैंने कहा कि pretracheal space extend up to the anterior mediastinum. मैंने कहा कि pretracheal, then we have retropharyngeal space extend up to the posterior mediastinum. मैंने कहा कि danger space extend up to the diaphragm. Trauma to which of the following structures could result in leakage of cerebrospinal fluid into the nasal cavity? I think ये भी मैंने मेरे ख्याल है
Cribriform
Cribriform plate of
ethmoid
ethmoid
bone.
bone.
Cribriform plate from the ethmoid bone. Good. A patient comes to a doctor with pain arising deep between nasal aperture and the external acoustic meatus. The pain is going via a sensory nerve supply of the face. Bit is sensory nerve supply of the face. Sensory pain
Mandibular
है.
nerve.
मैक्सिलरी नर्व।
अब इसमें से आप कौन सा करेक्ट ऑप्शन कहेंगे?
मैम बी।
Maxillary nerve.
मैक्सिलरी
Maxillary
नर्व.
nerve.
अगर आप इसीलिए मैंने आपसे
Maxillary
कहा
nerve.
था कि आप उसका जो मैप है, नर्व मैप, उसको अगर आप देखोगे तो आपको अंदाजा हो जाएगा कि किस एरिया की बात हो रही है. ठीक है? Then we have an embolus from an infected venous thrombosis in a facial vein is most likely to lodge in which of the following dural sinuses? ये भी मैंने बहुत दफा
Cavernous
repeat किया है.
Cavernous sinus.
Cavernous sinus.
Because this is very important. ठीक है? Cavernous sinus thrombosis बहुत important है. Now, अब ये जल्दी से बताएं. Number 13.
Against the second molar tooth.
Against second upper molar.
Again, second upper
Second
molar.
upper molar tooth.
ठीक है, good. Then we have 65-year-old lady complains of dry eyes. Which ganglion is most likely to be involved?
Ciliary.
ये जब हमने parasympathetic ganglion देखे हैं,
Ciliary ganglion.
Pterygopalatine.
pterygopalatine, because pterygopalatine gives off branches to the orbit, orbit pharyngeal palatine nasal branches, but उसका एक segment जो है वो lacrimal gland पे जाता है, और ये बात मैंने उस वक्त भी आपको कही थी. ठीक है? Pterygopalatine ganglion. Ciliary ganglion is for ciliary muscles only, and otic ganglion is for parotid gland, and mandibular is for major salivary gland, जो हमारे mandibular and sublingual gland. ठीक है? This is the last one. A 55-year-old lady underwent thyroid surgery. 2 days following operation, she noticed hoarseness of voice. The most likely damage is in which nerve?
Recurrent
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 laryngeal.
laryngeal.
Good. Because recurrent laryngeal nerve जो है वो हमने कहा कि all the muscles of the larynx are supplied, or again recurrent laryngeal nerve is the nerve supply of the thyroid too. तो
Picothyroid is
that's
supplied by the
picothyroid.
external laryngeal nerve.
External branch of superior laryngeal nerve.
good. ठीक. Thank you so much. I think time's up. अब हम इंशाल्लाह हमारी क्लास है नेक्स्ट मेरी आपके साथ रेस्पिरेटरी सिस्टम के साथ. आपके जो भी क्वेश्चन होंगे आप मुझे ईमेल कर सकते हो.
मैम
अगर कोई और
चैट बॉक्स
information
में अपना
चाहिए-
ईमेल दे दें।
अच्छा ठीक है, मैं इनको कहती हूँ मेरा ईमेल एड्रेस आपको शेयर कर देते हैं, और आपको प्रेजेंटेशन जो है वो इंशाल्लाह वो भी ये शेयर कर देंगे. थैंक यू सो मच.
No,
बहुत शुक्रिया.
excuse me, sorry, please.
Thank
Sorry
you,
to
ma'am.
interrupt. Sharing of slides and video recording is not permitted as per CPSP policy. Sorry for interrupting. Thank you so much.
मैं आपकी कंप्लेंट जो है वो उसको रजिस्टर करवाती हूँ जी. थैंक यू.
Dear participants, I hope this is helpful for the dentistry participants as they all really wanted it. So head and neck will help you in this regard by Dr. Yasmin Javed. Thank you so much. We'll have
Ma'am,
only
it's break now.
10 minutes break. come back
Okay.
because of namaz, Jummah prayers. Thank you all. क्या करेंगे? Compare करेंगे? अच्छा। मैंने उनको मैसेज किया क्योंकि उन्होंने कहा ना मैं स्लाइड शेयर देखा सबसे पहले मैं बता दूं। Dr. Tanvi Jilani will start at 11:10. ठीक है?
Yes, ma'am.
डेंटिस्ट्री से कोई बैठे हुए थे आज पार्टिसिपेंट्स?
Yes, ma'am.
उनकी एक कंसर्न थी, सो डॉक्टर शाही से मैंने डिस्कस किया था, तो उन्होंने कहा हेड एंड नेक में कवर हो जाएगा. आई होप इट इज बीन कवर्ड.
Respiratory भी करना होगा.
जी
Respiratory भी included है for dentistry.
जी जी.
Okay, ma'am. Thank you.
स्क्रीन शेयर कर लो इतनी देर, उसको म्यूट रखो, स्क्रीन शेयर कर लो, फिर आप जब पाओगे तो फिर मैं अनम्यूट कर दूँ. मैं कोशिश करूंगा जो ये पहला वाला लेना पड़ेगा, उसके बगैर शेयर कैसे होगा जी?
ये लाहौर सेंटर, ये जो डॉक्टर की स्क्रीन थी, इनको अनशेयर कर दें.
फोन नंबर है उनका, फोन एडमिनिस्ट्रेशन का, उनको फोन पे कह दो.
शेयर कर दिए.
जी थैंक यू.
उस पे लेने स्लाइड शो पे और फिर
बस ये
हाँ, ये
चैट निकाल के
आखिर में वो कमेंट्स फिलहाल important system in the human body. So I have till now talked about the renal system and the physiology of blood. Now the three topics, in fact, the four topics on which I'll be talking for next about 4 hours, inclusive of today, they all are the basic topics on which the cardiovascular physiology depends. And these are: number one, the generation and conduction of normal cardiac rhythm, which is also called as sinus rhythm. Number two, normal ECG. And number three, the cardiac cycle. Why are these placed simultaneously, one after each other? Because they all are interrelated very much to each other. Without normal cardiac rhythm, we cannot study normal ECG. And without both of them, we cannot go to the cardiac cycle. So therefore, I'll start the story with the first topic, which is generation and conduction of normal cardiac impulse and normal ECG. Can you hear me clearly?
Yes, sir.
Yes, sir.
Yes, sir.
So the learning objectives for my today's lectures are, I'll be trying to relate the functional anatomy of myocardium and the molecular events of myocardial action potential, which are depolarization and repolarization. Two, the path and generation of transmission of normal cardiac impulse through a specialized excitatory and conducting myocardial system. And I hope everybody has heard and learned till now about SA node, AV node, etc. And these all are called as specialized excitatory and conducting myocardium. Why they are called specialized, I'll be talking in a moment. And then I'll be trying to relate the functional anatomy and the normal cardiac rhythm to the basis and principles of normal ECG recording, including the description of its waves, leads, and interpretation. And after this one, I'll be referring to the cardiac cycle in my next lecture today. So, how many of types of the muscles do you know, which are present in the human body?
3.
Which are, can you name them? Can you name them?
Cardiac, skeletal, and smooth.
Okay, so the first two ones which you have named, which are cardiac and skeletal, both are histologically striated. And by the term striated, it means they have alternate dark and light bands, which are consisting of the actin myosin filaments. However, among the first two, which are cardiac and skeletal, as I said, histologically, they all are striated, both of them. The difference is that the cardiac muscle is involuntary and therefore is under the control of autonomic nervous system, while the skeletal muscle is voluntary and therefore is under the control of central nervous system. The third type of the muscle which you enlisted was smooth muscle, which are present basically in the viscera, skin, eye, blood vessels, etc. These smooth muscles are not striated and also are involuntary. So therefore, we know by our knowledge till now, by your undergraduate knowledge, that there are 3 types of muscles, whether you talk about anatomical classification or physiological classification. Now, I'll be talking about the functional anatomy of the first muscle which you enlisted, which is cardiac muscle. Cardiac muscle itself is arranged in 3 layers. And I hope you know what we mean by layer. Ek ke baad ek ke baad ek. The outermost layer of the cardiac muscle is called as epicardium. The middle layer of the cardiac muscle is known as myocardium. And the innermost layer of the cardiac muscle is called as endocardium. Endo means under, inner. So endocardium, innermost, myocardium, the middle one, and the epicardium, which is the outermost. These layers are wrapped around each other in a circular manner. We know that heart is placed on the left side of the chest, and its apex is directed towards our left foot. The heart consists of right atrium, left atrium, right ventricle, and left ventricle. But this is the classification of anatomy. In terms of physiological classification, functionally, physiologically, both atria depolarize simultaneously, and therefore they act as one unit. And this is called as atrial myocardial syncytium. Why they depolarize simultaneously and act as a functional chamber, I'll be talking in a moment. Same is the case for ventricles. Physiologically, right and left ventricle both depolarizes simultaneously as one unit. And therefore, they are termed as ventricular myocardial syncytium. Syncytium means a unit. Why there is a atrial syncytium and why there is a ventricular syncytium? In terms of their depolarization, which is followed by contraction. In terms of their repolarization, which is followed by relaxation. The answer lies in this diagram. Each one myocyte, which is a myocardial fiber, is connected with the adjacent myocardial fiber by this structure, which is called as intercalated disc. Intercalated disc actually are the fused cell membranes of two adjacent myocardial fibers. So myocardial fiber, which is also called a myocyte, number one, its cell membrane will be fused with the cell membrane of the adjacent, right side pe bhi, left side pe bhi, upar bhi, niche bhi, with the adjacent myocardial fiber at the site which is called as
Intercalated
discs. And at the intercalated disc, where the two cell membranes are fused, there are presence of thousands of gap junctions. And as the name suggests, there will be a gap between these junctions. These junctions contain hundreds of what are called as potassium, sodium leaky channels. And I hope everybody has heard about them in their role in the initiation of resting membrane potential. As the name suggests, the leaky channels don't have gates. They are ungated. So therefore, if they obey the law of simple diffusion, without any hindrance, sodium, which is present at rest normally in more concentration in extracellular fluid, can leak easily into the myocardial cell. And vice versa, potassium can easily leak because there are no gates from the intracellular fluid to the extracellular fluid through these leaky channels. In this manner, there is unhindered transport of these are sodium channels shown, these are slow calcium channels, and these are the potassium channels shown. Potassium in green, sodium in purple, and calcium in yellowish orange. Are you with me?
Yes, sir.
Yes, sir.
The heart, therefore, the cardiac muscle, therefore, is divided into three types of the muscles now. मैं अरेंज की बात नहीं कर रहा, टाइप्स की बात कर रहा हूं फिजियोलॉजिकली. One, atrial myocardium, which includes both right and left. Ventricular myocardium, which includes again right and left ventricular muscles. The first two of them, which are atrial myocardium and ventricular myocardium have got abundance of actin and myosin filaments. Therefore, they both are highly contractile. The third one, which is called as specialized excitatory and conducting myocardium, which I'll be referring in my rest of the lecture, has very less quantity or no quantity of actin and myosin. So therefore, the third type of the muscle functionally is non-contractile. If its function is not contraction, then why it is present and why it is given the name specialized excitatory and conducting? Because the story starts by an electrical activity and not by a mechanical activity. Electrical activity is referred to as action potential, which you know is divided into depolarization and repolarization. To start the electrical activity, this is not atrial myocardium. This is not ventricular myocardium. There is a specialized one, and the story starts in a moment from sinoatrial node. So sinoatrial node, internodal pathway which connects sinoatrial node to the AV node, interatrial path, this is internodal pathway, then interatrial pathway which connects the myocardium in the right atrium to the myocardium in the left atrium. The bundle of His, its left branch and right branch, and finally the Purkinje fibers. I again repeat the names: sinoatrial node, SA node, internodal pathway, interatrial pathway, AV node, bundle of His and its left and right branches, and Purkinje fibers. These all are non-contractile because they don't contain any significant quantity of actin and myosin, but they are specialized type of myocardium. They are called as myocardium, but not contractile. Why? The special function they perform is not contraction and relaxation, but generation of an action potential, which is called as sinus rhythm, normally only by the SA node, which is then conducted through the interatrial, internodal pathways, AV node, bundle of His, and Purkinje fibers to rest of the heart. Are you with me?
सर एक दफा ये लास्ट 2 पॉइंट्स रिपीट कीजिएगा पुरकिंजे फाइबर्स के बाद.
The specialized excitatory and conducting myocardium consists of SA node, internodal pathway, interatrial pathway, AV node, bundle of His, its left branch, right branch, Purkinje fiber. They all are non-contractile because they don't contain, all of them, any significant quantity of actin and myosin. If they are myocardium but non-contractile, what do? They perform a specialized function of exciting the heart. Which one of these do? Only normally the SA node, which generates the sinus rhythm. Why it is the only pacemaker, I'll be talking in a moment. The impulse then spread from the SA node through internodal and interatrial pathways to the AV node and to the rest of the atrium. And from the atrium, the impulse is then taken through the AV node, bundle of His, and its branches into ventricles. The branches then spread along with the Purkinje fibers, this impulse which generated from the SA node all over the heart. Are you with me? Do you understand this now?
Yes, sir.
Should I move forward?
Yes.
And again, if anything till now is not clear, please ask me because I'll not be repeating it. Whatever I have said till now.
सर
Okay.
रिपीट कर दो.
बेटे टाइम नहीं है आज. I have to cover 3 topics. कोई बहुत essential ऐसी चीज हुई जो आपको आगे आके हवाला हुआ, I'll be repeating it, but not otherwise the whole of it. Okay. Should I move forward?
Yes, sir.
Yes,
Yes, sir.
The sinoatrial node is the first part of the specialized excitatory and conducting myocardium. As I said, this is present at the superior lateral wall of the right atrium, near the opening of the superior vena cava. Sinoatrial node is a specialized type of the cells collected at one place in the form of a node. This has got maximum number of the gap junctions all over the heart, 1. Second, the excitatory rate, as I said, all are self-excitable, but the excitatory rate of the sinoatrial node is highest all over the heart, which is between 60 to 120 times per minute. So because of the last two things, kaun si last two things? Maximum number of the gap junctions all over the heart and the highest excitatory rate, which is between 60 to 120. The nature has made sinoatrial node the only normal pacemaker of the heart. Is this clear?
Yes, sir.
Now, the story of the sinoatrial node starts with the action potential. And usually what is the first phase of our action potential of any cell? The phase is called as? The first phase of action potential.
Depolarization.
Okay.
Depolarization.
When the sinoatrial node has to be self-excited for the first time and for all consecutive times, the sodium channels at this moment of time are closed. Therefore, the only channel which can bring a positive ion from ECF to ICF among the channels which I have enlisted, the only cation channel, zara gaur se suniyega mera jumla, sodium channels are closed for SA node. So therefore, the only channel remaining which can bring a cation, positively charged ion from the ECF to the ICF are
Calcium gated channel.
बेटा gated तो हैं, but उनका characteristic क्या थी? क्या लफ्ज इस्तेमाल किया था?
Slow to open.
Slow calcium channels. Sodium were fast to open and fast to close. So the story of the action potential of the sinoatrial node starts with the slow calcium channels. The resting membrane potential of the sinoatrial node is about -55 to -60 millivolt. This is the action potential graph, the middle one of sinoatrial node. At about -40 millivolt, the resting membrane potential कितना है? -55 to -60 millivolt. ये यहाँ टच हो रहा है, देखो जहाँ एरो है मेरा. The gates of the sodium calcium channels start slowly opening, and they all become opened at a threshold voltage of -40 millivolt. So the calcium channels which were slow to open start slowly open, and all of the calcium channels become opened finally at a threshold voltage of -40 millivolt. And can you see the graph has come slowly till the threshold voltage? This is not all of a sudden. देखो slowly आ रही है. -60 से लेके -55 से लेके -40 तक slow आ रहा है. कितना लंबा ग्राफ है, slowly आ रहा है. So finally at -40 millivolt, all of the sodium calcium, slow calcium channels become open. Calcium starts slowly moving in. And if it is moving in, it is bringing what charge from the ECF into the myocyte, which is SA node.
Positive.
Positive.
Not sodium, but calcium. Sodium are closed. Now, once most of the sodium channels have brought the calcium in, they start slowly closing. And at the peak here, at about 0 millivolt, slowly calcium channels start closing. Once all of these sodium calcium channels have closed and an adequate quantity of positively charged substances are bringing in, what happens to the original negative resting membrane potential? It will become what charge inside now? More.
Positive.
Therefore, now we say that all of the SA nodal tissue has become depolarized. Once the calcium channels do close slowly, starts the opening of second type of channels, which are potassium channels. Now, potassium channels, as I said, are relatively slower than the sodium, but not slowest. The slowest one are calcium. So the potassium channels open and they bring the positive charges from the ICF back towards the ECF. If now potassium is going out, there is a potassium efflux from inside the myocardial cell of the SA node to the outside cell. What charges are now going out? If potassium is going out, so therefore, if positive charges are going out, is there a regain of the original polarization?
Yes.
And therefore, this phase, because of the regain of the polarization, is called as repolarization. However, in the SA node, when the repolarization has to stop, this don't stop. Potassium channels remain prolongedly open for certain more time. And therefore, the graph of repolarization don't ends at resting membrane potential. It goes slightly below the resting membrane potential. And therefore, the second phase is called as hyperpolarization. So therefore,
मैं उसको वैसे ही फारिग कर देती हूँ, मेरे पास टाइम नहीं है उसको लिखने का.
डॉक्टर फरा अपना माइक म्यूट करें.
Therefore, SA node becomes depolarized due to dash influx.
Potassium influx.
Bete, I again repeat my MCQ.
Sodium influx.
SA node becomes depolarized due to dash influx.
Calcium.
Due to through slow calcium channels. And the SA node becomes hyperpolarized due to efflux of dash.
Potassium.
Potassium.
Potassium, beta calcium ka bahar gaya. Potassium. Once the potassium has gone out, would for a next action potential, calcium has to be brought back, or the positive charges has to be brought back to the ECF, and potassium has to be brought back to the ICF, or yes or no?
Yes.
And therefore comes at the end of the hyperpolarization, the role of ATPase pump. The ATPase pump the potassium back from the ECF to its original position to the ICF, and pump the positively charged ions from the ICF back to the ECF. Therefore, in the action potential of the SA node, there is involvement of dash, dash, and dash.
Repolarization, hyperpolarization.
And can you name the three structures involved respectively?
Calcium, potassium, and sodium.
An ATPase pump. So once the sodium SA node becomes depolarized, it transmits its depolarization wave into the underlying atrial tissue, which is directly connected with it. As soon as SA nodal depolarization is spread, remember intercalated duct and cap junctions, into the beneath atrial tissue. This atrial tissue now becomes depolarized. So one atrial myocardial cell, second myocardial cell, and onwards. And then this atrial depolarization wave is taken from the right atrium through interatrial pathway, is transmitted into the left atrium. And once the atrial depolarization wave has spread all over the atria, now simultaneously at the end, the atria, both right and left, which have been connected electrically through interatrial pathway, now simultaneously as one unit becomes depolarized strongly. This depolarization wave simultaneously spread from the SA node through internodal pathways. I have used the word pathways. Why? Because the internodal pathways are divided into three sub pathways, which are anterior, middle, and posterior pathways. They take the impulse from the SA node, anterior, middle, and posterior, shown as in this diagram, anterior, middle, and posterior. And the pathways take this impulse to the atrioventricular node. Atrioventricular node is just present above the atrioventricular septum. Once the impulse reaches the AV node becomes depolarized. However, AV node has got all characteristics which are opposite to the SA node. The AV node has got the minimum number of the gap junctions, is excitatory or the discharge rate is much lesser than the SA node. If there are minimum number of the gap junctions, do you think the impulse will go quickly to the ventricle or would stop for certain time in the AV node?
It would stop.
For certain times. And this is called as AV nodal delay, which is about 0.16 second. The significance of this is it gives sufficient time for the ventricles to fill up with the blood. And once the ventricles will be sufficiently built up with the blood, there will be sufficient pressure for the ventricle to pump. And remember, ventricle is a more stronger pump than the atria. The significance of the AV nodal delay is it provides sufficient time for the ventricles to become filled up before the electrical impulse is transmitted from the atria into the ventricle. Ji beta, do you understand this?